Hello, everyone. This is Tomoki Kosho from Japan. It's a great honor to have a chance to talk about musculocontractural EDS. I'm so sorry not being there, but my heart is there with all of you. Okay, let's start my presentation. I'd like to disclose my conflict of interest. No conflict of interest for this study. And also, I am a member of an endowed chair named Division of Clinical Sequencing, Tsinghua University School of Medicine, sponsored by 2 companies. This is the content of my talk. First, overview of the syndrome. Next, mcEDS CHST14, one subtype. And the next, mcEDS DSE, the another subtype, and the conclusion. And first, I'd like to talk about overview of the syndrome. And musculocontractural EDS, mcEDS, is a subtype of EDS caused by defective dermatan sulfate biosynthesis. And it is classified into 2 types. One is mcEDS CHST14, which is caused by biallelic loss of function variants in CHST14, encoding carbohydrate sulfotransferase 14, or named dermatan sulfotransferase 1. The disorder was independently identified as adductive thumb clubfoot syndrome by Dundu et al., and a specific type of EDS, which was called Kosho type by us, and the subtype of kyphoscoliosis type by Myfalt et al. And to date, 66 patients from 48 families reported in our world. And the another type is mcEDS DSEs, which is caused by biallelic loss of function variants in DSEs, encoding dermatan sulfate epimerase. And to date, 14 patients from 8 families at the time of our clinical and pathophysiological study recently. And I'd like to show you diagnostic criteria for this syndrome. Major criteria include congenital multiple contractures, characteristically adductive flexion contractures and or talipes equinovarus. Next, characteristic craniofacial features, which are evident at birth or in early infancy. And last, characteristic cutaneous features, including skin hyperextensibility, easy bruisability, skin fragility with atrophic scars, increased palmar wrinkling. And minor criteria include recurrent or chronic dislocations, pectus deformities, spinal deformities, peculiar finger shapes, and progressive foot deformities, and large subcutaneous hematomas, chronic constipation, and colonic diverticular, and palmar wrinkling, and pneumothorax or pneumohemothorax, nephrolithiasis or cystolithiasis, hydronephrosis, and cryptorganism in males, and some ophthalmologic problems such as strabisms, refractive errors, and glaucoma. And next, I'd like to talk about mcEDS CHST14. And genotypes are like this: 26 intragenic variants, including 13 missense, 7 frame shift, and 5 nonsense, and 1 in-frame deletions were reported. And interestingly, recurrent variants, including purine 281 leucine in 20 Japanese families, and phenylalanine 209 serine substitution in 10 Japanese families, and tyrosine 2 cysteine at 293 position in 5 Japanese families, and valine 49 stop codon in 3 families in the Turkish or Dutch descent. And next, I'd like to talk about perinatal history of this syndrome. Pregnancies were complicated in 36%, such as reduced fetal movement and hand or foot abnormalities and obstetric problems, and so on. And deliveries were eventful in 34%, such as cesarean section due to breech presentation and fetal distress. And neonatal periods were eventful in 89%. Congenital contractures, including talipes equinovarus, and poor sucking or feeding, including tube feeding, and hypotonia or muscle weakness, and cardiopulmonary problems such as apnea, cyanosis, respiratory distress, persistent pulmonary hypertension, repeated cardiac arrest, and hyperbilirubinemia, cryptorganism with or without inguinal hernia, and asphyxia, and so on. And I'd like to show you the lifespan of this syndrome. 9 deceased patients were reported, and the median survival time was 12 years for them, range 1 day to 59 years. And the causes of death were available for 5 patients, including respiratory distress shortly after birth, septicemia due to scalp hemorrhage at age 12 years, and infective endocarditis at 28 years, and colonic perforation at 37 years, and intracerebral hemorrhage at 59 years. Next, craniofacial features of the syndrome, and it is distinctive with some changes with age. In early childhood, a round facial shape with micro or retrognathia are observed. And in adolescence or adulthood, slender and elongated with a protruding jaw and crowded teeth and facial asymmetry are observed. And other features include characteristic forehead, dental problems, and bushy eyebrows, and broad nose and nasal bridge, and so on. Next, skeletal features of the syndrome, and characteristic finger morphologies were observed in all patients, tapering, slender, and cylindrical. And joint hypermobility was also observed in all patients, and multiple congenital contractures were in 98%, and progressive talipes deformities were also in 98%. And talipes equinovarus were 95%, and recurrent joint dislocations were in 90%, and which occurred in shoulders, knees, elbows, and hips. And the median age at the initial dislocation was 6 years, and 80% had the initial episode by the age of 10. And skeletal features, the next observation, spinal deformities in 87%, scoliosis, and sometimes mild and moderate and severe, and kyphoscoliosis, sometimes severe. And inner series and scoliosis and very severe thoracic lordosis and kyphosis at the thoracolumbar joint are observed, and cervical kyphosis and malformed vertebra and adult axial subluxation were observed. And 4 patients with severe spinal deformities underwent surgical correction successfully. And additionally, adductor thumbs, pectus deformities, osteoporosis or osteopenia, tendon abnormalities, and malformed habitus were observed. Next, cutaneous features are like this: a hyperextensibility in all, and fine or acrogeria-like or wrinkled palmar creases in 98%, and bruisability is also 98%, and fragility 90%, atrophic scars 84%, delayed wound healing 81%, and hyperaltitude pressure in 78%. And that shows the difficulty in blood pressure measurement in the upper arm. And recurrent subcutaneous infections were 37%, buttocks or elbows, and umbilical hernia 34%, and fistula formation 30%. Next, cardiovascular features. And the large subcutaneous hematoma was the most common complications in 81%. That occurred in the scalp, buttocks, thighs, lower legs, and leg and knee, face, and so on. And the median age at the initial episode of the hematoma was 6 years, and 80% have initial episode by the age of 12. And valve abnormalities were observed in 37%, majority the mitral regurgitation and mitral prolapse. and in 2% aortic regurgitation. And congenital heart defects were in 22%, and the most of them had atrial septum defects. And enlargement of ascending aorta is observed in 33%. Next, pulmonary and gastrointestinal features. And pulmonary pneumothorax were observed in 3, initially occurred at ages 23, 28, and 31 years. And constipation was the most common gastrointestinal findings, and diverticular in 35%. That occurred mostly in the colon and in small intestine stomach in only 1% patient. And perforation was occurred in 4 patients at ages 12, 24, and 29 years. And other gastrointestinal complications include abdominal pain, diarrhea, a frog croak-like large bowel sound, and gastric ulcer. And in a recent report, colonic perforation without diverticular in 2 siblings were observed like this. Next, genitourinary features and sexual development-related findings. And genitourinary features include cryptorchidism in male patient was the most common findings, and 88%, and hydronephrosis 51%, bladder dysfunction 50%, and recurrent urinary tract infection 32%, nephrolithiasis and inguinal hernia also about 30%. And sexual developmental related findings include poor breast development in females in 80% and hypogonadism in 14%. And the median age of menarche was 14 years. And next, ophthalmologic and otologic findings. And refractive errors was the most common ophthalmologic findings, and 93%, and strabismus in 66%, and glaucoma or elevated intraocular pressure about half. And retinal detachment was occurred in 35%, and the median age at the occurrence of retinal detachment was 15.5 years. And blindness was observed in 6% patients, which was associated with glaucoma, macular bleeding, lacunar crack in brush membrane or retinal detachment. And otologic manifestations include hearing impairment observed in about half. And in our institution-based series of systemic otological investigation on 9 patients, we found that high prevalence of hearing loss, 80% per patient and 78% per year, typically sensory neural and bilateral, with mild to moderate severity of high frequency or low frequency type, and sometimes with no DP or AE response. And this is the pathophysiology in mcEDS CHSD14 team. And skin hyperextensibility and fragility of the syndrome would be attributable to spatial disorganization of collagen fibril networks with disruption of the normal ring mesh structure of collagen fibrils, which is associated with abnormally stretching glycosaminoglycan chains of decrin, in which dermatan sulfase is completely lost and replaced by chondroitin sulfate. Next, I'd like to talk about mcEDS-DSE. And genotypes of the subtype is like this: 3 missense variants located in exons 4 and 6, and 4 nonsense or frame-shift variants located in exons 5 and 6, which suggests that messenger RNA decay is unlikely to occur. Clinical features of this subtype compared with mcEDS, the CHSD14, the original subtypes, are like this. A clinical picture of the mcEDS-DSE was essentially similar to that of mcEDS CHSD14, but significantly less common findings compared with mcEDS CHSD are joint manifestations, recurrent chronic joint dislocations, joint hypermobility, skin features such as hyperextensibility, bruisability, fragility, atrophic scars, constipation, hypotonia, motor developmental delay. This is pathophysiology in mcEDS-DSC. This I'd like to show you the skin specimen findings in a patient with mcEDS-DSC. And the left side transmission electron microscopic findings with cupromelanic blue staining. That staining could visualize gag chains and coexistence of normally assembled collagen fibrils with curved gag chains and abnormally dispersed collagen fibrils with linear gag chains. And disaccharide composition analysis shows the DS moieties of CSDS chains significantly decreased in this syndrome, but still present. These are consistent with 2 previous patients with this syndrome. And I'd like to discuss that the mosaic pattern of collagen fibril assembly in the syndrome may be related to the milder skin involvement in mcEDS-DSC, and the possible underlying pathophysiology could involve residual activity of DSAP1 encoded by the DSC gene, and or compensation of another minor DSC named DSAP2. And based on these clinical evidences, we established a healthcare guideline of this syndrome. On diagnosis, systemic surveillance to detect multiple congenital abnormalities or complications are recommended. And in childhood, regular evaluations such as orthopedic, cardiovascular, urologic, ophthalmologic, otologic, and dental are recommended. And after walking independently, special attention for gait instability due to progressive talipes deformities and muscle hypotonia should be paid, because they could result in injury-related joint dislocations, skin lacerations, and large subcutaneous hematoma. And foot orthosis for talipes deformities are important. And intranasal DDAVP desmopressin therapy for large subcutaneous hematomas are also very important. And in adolescents, close orthopedic examinations for possible progressive spinal deformities are required, and wrist, not upper arm sphygmomanometer are also recommended, because the measurement in the upper arm is very, very painful for these patients. And psychosocial support for adaptation to disability and enhancement of self-esteem is crucial, and consultations with teachers and employment specialists for limitations in school activities and future employment is also very important. And in adulthood, regular systemic evaluations and genetic counseling such as reproduction issues are needed, and management of acute serious complications such as dislocations, skin lacerations, large subcutaneous hematoma, diverticulitis with or without perforation, and pneumothorax, retinal detachment are very important in coordination with emergency room and intensive care unit and relevant departments. And in conclusion, mcEDS is an established and probably not so rare subtype of EDS. Clinically, the disorder is characterized by multiple malformations such as craniofacial features, multiple congenital contractures, ocular and visceral malformations, and progressive fragility-related manifestations such as skin hyperextensibility and fragility, joint hypermobility with laxation, progressive spinal and foot deformities, and large subcutaneous hematomas, and visceral ruptures. And molecularly, the disorder is caused by loss of function by allelic variants in CHSD14 or DSC. It indicates autosomal recessive inheritance. And pathophysiologically, the disorder is associated with a spatial disorganization of collagen fibril networks with disruption of the normal ring mesh structure of collagen fibrils, associated with abnormally stretching gag chains of decorin in which dermatan sulfate is completely replaced by chondroitin sulfate. And healthcare management through multidisciplinary approaches is recommended. And lastly, future agility-based therapy is expected. And special thanks to the team mcEDS in Japan, many researchers and clinicians. And also, I'd like to thank many clinicians contributing our international collaborating work for this syndrome. And these are funding we have obtained. And thank you for your attention. Thank you.